Hello everyone and welcome to your Medicare Monday, and in today's video I kind of wanted to talk a little bit about the kind of inflationary issues that could impact healthcare spending, probably healthcare premiums, and just overall healthcare in retirement. Also want to talk a little bit more about Medicare Advantage and how it's kind of hurting the system, and also something that's kind of, I guess, has been or is going to hurt again the overall financial security, I guess, of Medicare. I'm going to more of that a little bit later, and we'll talk about the most costliest kind of medical, I guess, procedures that is in America. Okay, so let's go right into it. So first, we'll go ahead and talk about the healthcare and inflation. So, healthcare, of course, is very expensive. It's one of the most, I guess it's the most expensive kind of event when you go on to into retirement. Medical, not just talking about Medicare and your premiums that you pay for health insurance and such, but like long-term care, right? And all of those factors, just keeping yourself healthy, it's costly. And if we assume that, inflation keeps going up keeps going up and drives cost of medical up, what then would that mean for our, I guess you could call it, our budget, right? When we retire, as a person who is in financial planning, who charter retirement planning counselor, certification, long-term care planning, I myself have spent a lot of time academically and both in practice kind of trying to figure out what the cost is for someone in retirement who is retiring. What is their overall risk, right? Their health risk, their medical insurance risk, and how much of that are we going to purchase insurance for? How much is that insurance going to cost? And what is the projected insurance inflation amount, right? Insurance medical premiums do get expensive for both long-term care and Medicare, both Part B, Part D, and the Medicare supplement plan. So if we look here in this little healthcare cost inflation drivers, we find that for, just having 1 or 2 years of inflation will increase healthcare costs by a whole lot. If you can see, a healthy married couple with just 1 year of 11.85% inflation, that's gonna boost costs quite dramatically, $46,000 over the course of their lifetime, and just one bump, and then it throws off everything else, because now each year you have an additional 11.85% of costs. Now the next one estimates a 15.8% rise in health costs, and of course that one's going to be much more dramatic, right? I mean, we're looking at huge increases. And if you are younger than 65, this chart breaks down from someone who's 65, and if there's 1 or 2 years of inflation, and then of course if there are, at a 55 age, 45 age. So for me, I mean, geez, I'm going to be 38 this year, so I'm looking at, just one blast of small inflation, I mean, of 11.85%. I mean, CPI reached 9.1. We still haven't really felt what the medical community is going to start pushing for, their wage spiraling happen, right? Spiraling upwards. They had a huge rate inflation. We have a medical staff shortage. I can't imagine medical costs being any lower with every other cost going up, right? It's bound to catch up soon. So I can see that for myself too, costs will be greatly impacted by inflation. And this is just some of the costs that they're kind of saying could go up in retirement, right? Looking at, for someone 65, just 1 to 2 years of inflation, we're almost at 100,000. And if inflation does hit double digits in 15.8%, we're looking at 72 to $148,000 of overall cost inflation. Now, this is not 100% driven into, like, let's say your premium or whatever. Some of it is going to be subsidized by Medicare, and this is for healthier folks, so this is estimating to age or to life expectancy, and that can also compound costs. So what exactly are the costly things that are driving this? Well, there's an article here, the costliest claims. I most likely will link this article as well, but the article says that the most expensive claim obviously was COVID-19 in 2020. 2021, that is, the total spend of that was $114 million. But that's not all that costs a lot. Cancer is still the number one cost driver. Here we have the top 20 highest claim costs, and this is I believe it's for 2021. 2021. And malignant neoplasm, which is pretty much just saying cancer in a different way, has a $294 million reimbursement. So that means that what insurance companies paid for in claims towards these services that insurance companies pay. And just to give some context, Sun Life is like a reinsurance company. So what they do is, let's say you have a policy from Blue Cross Blue Shield, and Blue Cross Blue Shield will sell the risk or buy risk protection, whichever way you want to say it. What they do is they say, okay, I have 1 million members, and if any one of my members reaches a claim that's over, let's say, I don't know, $50,000, then at that point Sun Life will take over paying those claims. Everything under $50,000, Blue Cross Blue Shield will pay for out of their reserves, but anything over $50,000, then Sun Life will start picking up those claims. So Sun Life is kind of like they're the reinsurance company, like an umbrella insurance policy or a super high deductible plan for the insurance company to purchase, so that the insurance company, Blue Cross Blue Shield's risk is not unlimited, right? They have a cap on the amount of risk they can take, and pretty much Sun Life just deals with the super high cost claims, which is why they can produce such a good report. And basically, it's showing that cancer is one of the ones that is the most expensive. And I tell people time and time again to purchase cancer insurance, because even on programs like Medicare, like the Affordable Care Act, like employer coverage, cancer can cost a lot of money, and you'd be more than likely to hit your maximum out of pocket on a group plan, on Obamacare plans. And if you have to hit your max, or if you get these kind of ailments midway or toward the end of the year, you're going to be paying your max out of pocket 2 times, your deductible 2 times. Even for those people who are on Medicare, for example, you will have a Part B deductible, which is minimal, $233 in 2022, but your Part D, if you have to take it would be behind the counter pharmacy items, then what happens is you'll be going through your coverage gap all the way to catastrophic phase, and you could have to do that one more time again. So what happens in Medicare Part D, and this is the huge problem because Medicare is really confusing. Part D of Medicare covers medications. Part D of Medicare has 4 stages, in addition to having now 6 or 7 tiers of medication. And also those stages do depend on the insurance plan you pick. But to make it easier, pretty much if you pay out of pocket about $8,000, your cost of the medication will drop down to 5%. But a lot of these cancer medications cost $15,000 a fill. So even at 5% of $15,000, it's still a rather large amount. And then if you are still taking this and you flip over to a new year, you're looking at paying that entire, again, $8,000 pretty much to get you into the catastrophic phase, and then paying more. So it could be really expensive, which is something that a lot of people really aren't prepared for when it happens, and unfortunately cancer happens quite often. So just something that I like to talk about and have people think about. You don't have to buy insurance, you just have to be prepared for what happens or what you will do when it happens. I am someone who believes in just being prepared, just having a plan. You don't need to buy insurance. I'd be much, of course, financially happier if you bought insurance, but you don't have to. I'm just here to provide you with a subset of options instead of telling you whatever one works for you is the one that you should get. Another thing, as we talk about the Part D problem, the Democrats have decided or are trying to push through that wonderful Medicare drug price negotiations. So what they're trying to do is to put a cap on Medicare Part D drug spending to $2,000, which would be excellent, be awesome. And that would save a whole lot of folks who enter the donut hole and enter the catastrophic phase from having to pay any more money once they hit that $2,000. Now, the problem that I guess I have with this is I don't see how it's financially possible. If it was fiscally possible at all, they would have, number one, back in 2019 when the donut hole was supposed to be eliminated from legislation, I feel like they should have truly gotten rid of it, not just changed the way that the donut hole works. We still have that third phase, which is the donut hole in the Medicare coverage system, and what the bill did to destroy or to close the donut hole or close the coverage gap was they changed the coinsurance amount from 47% for generics, and I believe it was 35% for brand, to just having it as 25%. Now 25% is still a lot of money, considering that a lot of these medications are $800-900 a month, and when you're paying a copay it's $45. But for someone who has an $800 per month medication, you are going to hit the coverage gap and go from a $45 copay to 25% of $800, which just by quick math is about $200. So you're looking at going from $45 a month co-insurance, copay, your out-of-pocket expense when you see the pharmacist, to $200. And you're going to be paying that $200 typically for the rest of the year, because you will not even hit the coverage or the catastrophic phase, which is stage 4, because you have to spend $7,500 or so in cost, in how much you pay to meet the troop. Now it changed a little bit as the pharmacy company now has to contribute about 70% of the cost of the medication that counts as your troop, but still, it's still really confusing, and it didn't really help most of Medicare beneficiaries. Now this will probably impact $2,000 is a lot of money, but $2,000 is probably not where a lot of the problems are. So what I see is all these plans, your $7 per month plan, $10 per month plan, all of those plans will disappear, because now the only way to make this $2,000 cap maximum out of pocket for drugs, in order to make that happen, money got to come from somewhere. So the Part D plans, in my opinion, the only way that this could happen, I could see, is if the Part D premium was increased substantially, and 2, formularies got a lot more restrictive. So what that means is you will no longer have these plans that cover 2,000 medications. They might only now cover 500. They will only cover the mandated amount, which is 2 medications per treatable Medicare covered ailment, disease, diagnosis. So if that happens, the plans either will be, or both, really expensive or really restrictive, because the money got to come from somewhere, right? They can't just write it into existence. It's not going to happen. All right, so in addition, this Build Back Better bill, or the putting a cap on Medicare Part D, also talks about the negotiations, right? So that's the major part of the bill is about having Medicare negotiate drug pricing for medications, which will be beneficial in the long run to all people who have health insurance, because ACA, Affordable Care Act, Obamacare, employer plans tend to follow suit after Medicare makes decisions, which will have a overarching kind of cost structure benefit to people on the Medicare program and people who are just in America having to use this healthcare system. Now, for the negotiation portion of it, it's rather, in my opinion, a small portion. Probably has a great magnitude of budget implications, because every year what the bill is saying is we can take 10 drugs and we can negotiate the price on these 10 drugs, and every year we'll just add 10 more. And what that'll do is that'll attack kind of like the super high reimbursement items, like from before on that Sun Life highest cost claims condition. We're going to probably tackle the highest costing list on these 10 medications, or the top 10 on these medications. We'll figure out how to negotiate down the prices on there, right? Maybe we're going to try and work a little bit closer with the pharmacy manufacturers and see where the costs are, and see if we can, have other companies produce it on license, which is something that the medical community hasn't really explored. I think I did a video maybe a few months back now talking about how what they did with the COVID, where they're having not all the drugs be produced by Pfizer, but because of the state of this kind of state of things, the government exercised a kind of right that the government has in times of catastrophe, where they could force a company to provide the patent to another company and have that other company produce the said vaccine because we need the manufacturing capabilities, and then that company would pay royalties in kind of the, magnitude that Pfizer requires. And what that would do is it could make costs more transparent, and also drive down cost for all, and have access for all. Now, what this would do is every year they would kind of add 10 more names onto their list, or if it was I can't remember if it was every 3 years, every 5 years, but it was some slow kind of process. But the second part of this portion of this bill, what they're aiming for is to hinder or to stop the price acceleration of these brand name medications. I've been doing this cost analysis for Part D for my clients, because I found that many agents weren't doing this, and I like numbers. It was super fun for me to figure out which could save them the most money. Even though it didn't make me any money, it does help my clients a lot. So I've been doing this since 2014. And I've seen prices of medications only go up. All of them. Brand names, of course, go up notionally higher. I was looking at a medication, I believe it was Jardiance. I remember when Jardiance was right about $480, $500 retail. I looked it up this past weekend for a client. It's now $890. So it's almost doubled within the last, let's call it 8 years, which seems, to me anyway, rather the wrong way, as you would think that as medications are on the market for longer, their price should either stabilize or go down, because I would think that it should be that way, because when a drug initially hits the market, we're paying for all these the research and development, and then as the drug becomes not as novel, not as new, price falls off. That's why we have less expensive generics and things of that nature. But these brand name medications do not seem to go down. And another aspect of this bill is to push those drug costs from accelerating price increases. So good. I think all in all, this is good. I just worry about, as I worry about everything, when anything like this passes the execution, like the Affordable Care Act. In theory, Affordable Care Act was a phenomenal step in the right direction. Have every American covered. Have no pre-existing conditions as part of the health insurance. Have everything that's essential to people covered. And then when it came to the market, it was many people have different opinions than I do, which is fine. But as good as it is not, I feel like it is not in the light of what the law and the act wanted it to be, because we still have all the underlying problems, like healthcare delivery in places where healthcare isn't as available, and of course we have still pretty high, prevalence of disease and of sickness. So it's not the perfect solution, but again, hopefully a step in the right direction. Now, another thing, Medicare Advantage and profitability. So I thought this was really interesting because, again, when I initially, and all people who have talked to newer agents or even older agents who are Medicare agents who are trying to promote Medicare Advantage plans, Medicare Advantage is in itself, at the first layer and second layer, not a bad thing. And if you have a good agent who's helping you get the most out of your plan, it can be a good thing for people who are unable to afford Medicare supplement plans and a Part D drug plan. It sometimes Medicare Advantage is the only way some of these people who are retired can actually get access to the healthcare system, because if not, the costs of hospitalization, of surgery, of just going to the doctor could be something more than they can afford. And Medicare Advantage kind of opens up that group of people to have access to the medical system. Now, it's not going to be, I won't go into quality or anything like that, but just that's kind of what Medicare Advantage is for, in my opinion. And Medicare Advantage, from a overview position, they're supposed to help keep seniors healthy, and they're supposed to have a within reason profit margin. And I believe this article says that the profit margin is about 4.36%. And additionally, you're supposed to, if you make more than like allowable amount, let's say if a huge Medicare Advantage plan made like 10% profit margin, they would have to give back to the federal government some of those profits, because you get federal funding. You're not supposed to have like a huge markup on your services. I have found out through this article that if I'm a Medicare Advantage plan, and which many Advantage plans do this now, it's not something that's new or rare or a scam. If I'm a Medicare Advantage company and I say, you know what, I'm gonna subcontract my provider network team. So if I don't want to manage the provider network myself, I'm going to hire out a third party to manage my provider network. And then that provider network then turns and say, okay, I can manage your provider network. This is how much I charge. That's fine. Yep, so the provider network, and let's say their profit margin is like 50%, something outlandish. Well, that's okay, because the Medicare Advantage company isn't the one making those huge profit margins. Now, the rub is this Medicare Advantage plan can actually own that third-party physician network group and such, get those 50% profits, but through a different entity, not the entity of the Medicare Advantage plan. Now, it is not that simple. There's probably a few more layers that happen, but yes. So again, I had new agents. When you go into the market, when you start doing this, you're told that Medicare Advantage plans are angels, right? They allow people to get access to care. They give the member more benefits than original Medicare. They have a maximum out of pocket, and they're not even allowed to make a lot of money. Unfortunately, a lot of that is true from a certain point of view, to quote Obi-Wan Kenobi. So just kind of, that's kind of what's happening. And to make matters one step worse, where's my mouse? I have 3 monitors here. Here it is. Medicare, in their wisdom, has decided to make Medicare, traditional Medicare, look like an HMO. And how do they do this? By direct contracting, or what do they call it? It's the DCE model. Well, the DCE model, direct contracting entities. Okay, so direct contracting entities, you can think of them as like a hospital system. And this hospital system can see people who have Medicare Part B and A and B. But Medicare contracts them as DCEs, or Affordable Care Organizations, ACOs, or there's a whole different skew of different payment models where the hospital group now function as an HMO. So if you have Parts A and B, and you are with this DCE, this direct contracting entity, they can actually say, you know what, Medicare, this person has been with us and is with us, and we have enough data to say this person is going to be with us, and we are going to utilize all of our providers in this closed direct contracting entity. Then now they can bill Medicare like a Medicare Advantage plan. And you might be thinking, well, how does this affect me? I pay the same amount as I would anyway, right? If I have a Medicare supplement plan, I have a Medicare, drug plan, I still have the same freedom and flexibility to go wherever I want. You do. But what is the one thing that Medicare Advantage plans do great against our federal government? They milk them. And they milk the Medicare benefits from the entire Medicare Trust Fund, which, by the way, is running out of money, right? We may have foregone the 2026 bankruptcy, or not bankruptcy, just not being able to meet their expenses to 2028, but we're still hurting. And what this is allowing direct contracting entities to do is to suck more money out of the overall Medicare program. And if you're someone who believes that the Medicare program is in danger, is running out of money, then this is something else that is a new way that popped up out of nowhere to begin sucking more benefits out. And the interesting part is that if you are in this scenario where your physician or your hospital entity is one of these DCs, you don't even need to know about it. You won't probably know. There might be a letter in the waiting room that says, we are a participating this is what happens. Nothing really happens to you, but this is what we do in the back end for Medicare to increase funding for our hospital. And there's a whole bunch of it. I'll put this list also in the description, in the email as well. So be careful out there. Medicare is under a lot of scrutiny, under a lot of stress, but the things that are being proposed to take care of it can be misinterpreted for the negative. Like I said, right, we talked about the high cost of medications and Medicare negotiating those medications. That might be a good thing for everyone, right? Overview sounds great, but if this means increasing Part D premiums, decreasing Part D coverage, medications, and almost having an insanely difficult and expensive way to get your Part D drugs, that may be what happens. Like I honestly can't see how it wouldn't happen. Again, also Medicare Advantage looks like it's going to save money, never saved money, cost more money to the government, causes private entities, private equity firms, hedge funds to buy these companies because they're so profitable, because they can hide where the profits actually went. And then this backdoor kind of a way for Medicare to get, just constrained even more by private companies. It's just another way of, all of these programs which sound good in, I guess you could call it, in the from the top level, and when you actually look and peel back all those layers, you're like, wait a minute, this is just one big scam. And that is why I have these videos out. Not many people watch them, I know, but I feel like it does help those few people who kind of want to know what's going on and be a little bit more involved, or at least know what's going on, because many of these articles aren't, they're marketed toward either people who are like doctors who don't have time to read them, not in policy most times, and they just can't be. It's too expensive now to all the constraints you have as a physician. You can't run a business really unless you're like working 30 hours a day. And health insurance agents who most times only want to sell, so we don't even look at these things. But I spend a good majority of my time just reading this kind of stuff, just to be more involved. Anyway, this video became way a lot longer than I thought. Have a great rest of the week. Be safe, stay cool, and I'll see you in the next video.